Good deal. So this will be our first case. This is a 77-year-old woman who presents with numbness that's been progressive over a couple of months, some urinary symptoms, and has had more and more difficulty walking, requiring a walker to ambulate. No past medical history. Physical exam is limited because it's a telemedicine visit, but we know she's got some weakness affecting the lower extremities and possibly some sensory changes there, but no symptoms involving the upper extremities. So some other things we might want to know for this patient, Kat.
Is she having any pain in the legs?
Not really pain, just the weakness and the numbness. What about, is there anything else about her medical history that you'd be interested in knowing?
I mean, any prior diagnoses?
Yeah, any other history, particularly if she's ever
Like
had
cancer history or
any.
arthritis or...
Sure. So she does have a history of breast cancer.
Okay.
Early thoughts on differential, just in terms of things that could cause numbness and weakness in the lower extremities only?
I mean, my first thought would be to look at the thoracic and then the lumbar spine.
Yeah, good. So, kind of going through all the different possibilities before we look at the imaging. Obviously, tumor would be up there, especially with a history of cancer. We could also think about a syrinx, but we might expect to see more sensory than motor changes early on, and then some other things that would be non-surgical. So what do you see here?
Looks like there's a mid-thoracic mass lesion compressing the cord pretty significantly at about, T6 maybe.
Good. You think it's
Contrast enhancing.
intradural or extradural?
It's probably extradural. It's hard to tell on my screen, but
Yeah, it's
extramedullary for sure.
tough to say. Definitely extramedullary. Agree. Do you see anything else on the T2?
Cord signal change.
Yeah,
And then below it, there's a syrinx, kind of small
that's
syrinx.
right. Yeah, it looks like there's also a syrinx there below the tumor.
Mm-hmm.
I hate to interrupt Josh and Kat, but that image that you showed is classic, and you should be able to tell us whether it's intradural or extradural from that. It's not hard to say. It's very obvious. What do you see in the subarachnoid space ventral to the spinal cord?
CSF.
Right. Is the space getting bigger as it gets toward the lesion or smaller?
Larger. So I guess it's intradural.
Yeah, exactly.
Thank you, sir.
I'll mute myself again.
Good. So we covered that and the syrinx. So what would be the differential based on what we've seen?
The first thing would be metastasis from a prior cancer history or a new diagnosis of cancer. It could be like a peripheral nerve sheath tumor that's growing in the canal. It's unlikely.
Good. Yeah, I think, metastasis intradural is a little less common, but definitely could be a schwannoma. Should also definitely be thinking about a meningioma, as you'd mentioned with nerve sheath tumors and neurofibroma. So how would you approach treatment for this?
I think the best treatment would be transpedicular approach with ventral decompression of the mass because she's symptomatic and there's a lot of cord compression.
So
requires surgery.
You would say straight to surgery? Okay. Yeah, that's definitely reasonable, especially based on the imaging. I think we can be pretty confident about what the tumor is, and would not try to just do a biopsy alone.
All right. So this is the smear that we do intraoperatively at the time of the frozen section. We like the smear because it provides us with very good cytologic characteristics. In the center of the field, you can see what we call whorls, which are pretty much diagnostic of meningothelial differentiation. Next slide, please. And so this is the cytology. I don't see any atypia, pleomorphism. Since now we decided it's meningioma, we want to make sure it's not atypical. In the center of the field, there is a dark cell with a round intranuclear structure, and that's what we call pseudonuclear inclusion, right in the center of the field. Next slide, please. This is the histology, which is consistent with what we saw in the smear. The round structures are the Samoma bodies, which are dystrophic calcifications that are commonly seen in meningiomas and some other tumors as well. But when it comes to CNS tumors, every time we see Samoma bodies, we think meningioma until proven otherwise. On the top of the slide, you can see a dense fibrous band, which is the dura. So this is a dura-based tumor with features of meningioma. Next slide, please. And this is a closer look, just to show you again the cytologic characteristics and the Samoma bodies, which are also characteristic of meningiomas. Next slide. The only stain that we need to do here really is Ki67, just to assess for the proliferation marker, and this would be around 1%. So it's a grade 1 meningioma of the spinal dura.
Good. Yeah. So the patient did undergo surgery for gross total resection of the tumor. And just a quick review on the right is the Simpson grading scale. You know, these tumors in the spine, you're usually not going to go for a Simpson grade 1 or 2, especially if the tumor is ventral. You're not going to remove the dura, rather just coagulate it. Spinal meningiomas, similar to their cranial counterparts, are much more common in women. They usually happen in the thoracic region, and the presentation in this patient's very, very common. A good portion of these patients are a little bit older to begin with, and so they commonly will have started using a walker recently. By the time they get to the office. So moving on to the next case. In this case, we'll have a 39-year-old woman with a history of MS, who, as part of her workup for MS, was found to have a brain mass. She has had headaches for 6 years, which are not related to the mass. As well as some vague sensory complaints that are related to the MS. She said recent growth of the tumor on MRI. Past medical history is only remarkable for hypertension. Physical exam is unremarkable. Vignesh, can you describe what we've got on the MRI here?
Hey, sorry. I don't think my the speaker is working. So this is on the on the left. You have a T1 T1 MRI without contrast. There's like a sort of pedunculated mass inferior to the cerebellum behind the brainstem, and then on the I guess we've got a contrast enhancing mass. We've got a contrasted MRI in the middle. doesn't look like it's very avidly, doesn't look like there's any contrast enhancement at all there. And it does not restrict on DWI.
Yeah, that's great. Exactly. So this, there's some features that you described that could really help us narrow down the diagnosis. Do you have any thoughts on what the type of tumor might be?
I guess given its location, I guess you could consider foramen magnum meningioma, but I guess meningiomas are typically contrast enhancing. Uh, I guess you would also be worried about maybe like a brainstem, I guess a low-grade glioma.
Yeah, so meningioma, based on the location, would be good, but like you mentioned, probably less likely since the tumor is not enhancing. If it were enhancing, you could also think about it being a nerve sheath tumor. Those can also be in that location. Our differential would be much bigger if this were in the fourth ventricle. It's kind of hard to say on those imaging whether there's any aspect of the tumor in the fourth. I can tell you it's not really, but it's sort of coming out of Magendie. But one to keep in mind for boards, sometimes they'll show a picture similar to this, and it's neurocysticercosis can be a cyst there. And then, if we think about tumors just generally in the brain that don't enhance, that can occur near the ventricles, you think about dermoid, epidermoid, and subependymoma. And then in terms of surgical approach, Vignesh, do you have any suggestions?
Yeah, I think you could probably approach this from a suboccipital craniotomy with a with a C1 laminectomy as well for other exposure.
Yeah, good. Would you need an EVD for this case?
I think it would probably, I think it would probably help just for like I guess like relaxation of the basal cisterns.
Yeah, without hydrocephalus pre-op, you probably don't need one in this case. So just what you said.
All right, so this is the tumor at low magnification. The low magnification is very important in this particular tumor because it shows us a nodular growth pattern. Next slide, please. This is a closer look at the bottom of the picture. You can appreciate the nodular growth pattern. And on the top, there is some dystrophic calcification. In CNS tumors, dystrophic calcification is traditionally associated with slow growing processes, and this is not an exception. This is a subependymoma. And next slide, please. And this is higher magnification to show you the fibrillary background, which is very important to recognize in this particular tumor, and also the cellular characteristic. Atypical features, remember atypical features in CNS tumors are mitosis, necrosis, vascular proliferation. Neither of them is present in this particular case. And Ki67, which is on the next slide, is about 1%. So this is an example of subependymoma, which is grade 1 according to the WHO classification of tumors.
Yeah, so just a few things about subependymoma. One, the tumor is probably more common than we recognize. It's often asymptomatic, and some anatomical studies have found that it's postmortem in about 0.5% of all people. These are most common in the fourth ventricle. This one was below that area, and worth noting too is that the exception is if it's a subependymoma within the spine, it is more likely to present with the deficit than a tumor in the brain. for obvious reasons. This is just a nice nice illustration showing the pattern of growth of these tumors. And again, you see the tumor arising from the septum pellucidum on the right is a common location for these tumors in the lateral ventricles. So on to case 3. In this case, we have a 62-year-old woman who was referred with a newly diagnosed brain tumor, and we have some outside imaging that we're going to review. Her medical history is remarkable only for hypertension. Damien, are you able to hear me?
Yep, can you hear me?
Yeah. Do you want to just take a stab at describing what we see here?
Sure. So the left image looks like a T2 MRI, and the right one as well. Middle looks like a T1 without contrast. There's a lesion, looks like front of the midbrain. Looks intraaxial, kind of coming from the temporal lobe.
Yeah, definitely. Good job. So it looks like a intraaxial tumor, probably coming from the medial right temporal lobe, and it's extending toward the midline in front of the midbrain and to the suprasellar cistern. So while this patient's in clinic, she starts to complain of a severe headache and vomits. So she's sent to the ER for a head CT. While she's in the scanner, becomes unresponsive and has some clinical signs of herniation. So this is the CT scan that was done there. Damien, what do you think has happened here?
Well, it looks like there's a lot of subarachnoid blood. The tumor probably hemorrhaged, and that was causing a lot of, it's like obstructive, maybe not obstructive hydro, but I mean, she's got uncal herniation on the right side there. If you could explain the pupil dilation.
Right. So let me move to the next slide. So in terms of differential, is there anything that comes to mind that might have caused this?
Some sort of hemorrhagic tumor, like maybe like a renal cell carcinoma metastasis. But other than that, I'm honestly not too sure.
Yeah, no, this is a tough one. I liked where you were going earlier when you said it looked like an intraaxial tumor, because it did on the pre-op MRI. But you're right, there's some metastatic tumors that would have a tendency to bleed. You know, looking at our differential here, is there any other imaging you would try to get maybe while the patient's in CT?
CTA.
Yeah, definitely. So, you know, CTA is fast and can be done right then while the patient's getting the plain CT. It just adds a few minutes and can give us some really valuable information if there's any other underlying vascular issue here. And then once the patient's done with the CT and the CTA, what would your next steps be?
Sorry, I was muted. You'd want to reduce the swelling in the brain and treat, you know, the subarachnoid. Blood pressure management, or I would say, would this be someone that would need an EVD as well to reduce some of that pressure, even without hydro? I'm not sure. And then, I mean, I think they also need surgery eventually too, to treat the tumor.
Yeah, eventually, or like what time frame?
Well, I mean,
Like
they're obviously herniating, so I guess would you just take them directly to the OR for operation?
Yeah, definitely. So, anytime you're dealing with a case where you've got obvious clinical signs of herniation, we've
Okay.
seen it on the CT scan, whether it's a trauma or, an aneurysm or a tumor that's bled, that has to be dealt with right away. So in this case, as you'd mentioned, looking at the CT scan, it looks like a tumor that's probably bled. So the goal of surgery in this case. Do you think that the more important part of the surgery is doing the decompression, or is it more important to try to get all the tumor out?
I would imagine decompression, given the herniation, and it would probably be difficult to get all the tumor, given that it's bled already.
Right. Yeah, definitely. So, the main thing is to decompress the brainstem. So, a wide craniotomy, removal of as much of the blood as possible. And then, at that point, once the patient's been stabilized, you can decide how aggressive you want to be with the underlying lesion. And that's what was done here. And as you mentioned, an EVD was placed. They also did a anterior temporal lobectomy, both to remove some of the tumor and to assist with the decompression.
Okay, so this is a tough one as well for us as pathologists. I'm going to tell you this is an ependymoma. It's the tanicytic type, and I'm going to show you the features. So in ependymomas, you're supposed to see the ependymal pseudorosettes and so on. This is an exception. By histology, this one looks very much similar to astrocytoma instead of ependymoma. So a high level of suspicion should be present to be able to arrive to this conclusion. So unfortunately, I'm not able to use my arrow here, but on the right-hand side, there is what we call palisading of cells, and the background is fibrillary, which is very, very characteristic of astrocytic differentiation rather than ependymal differentiation. However, I'm sure you'll be able to appreciate the tumor cells are arranged in what appears to be fascicles, like they're streaming, following streams of some sort. Next slide, please. And this is higher magnification to show you necrosis and also a closer look of the streaming or fascicular growth pattern. And next slide. In the center of the field, you see obvious necrosis, and the tumor cells here become significantly atypical and pleomorphic to the left-hand side. Next slide. This is a closer look to show you the numerous mitosis and apoptosis, significant atypia and pleomorphism. So in ependymoma, the highest grade would be anaplastic, which is grade 3. And anaplastic ependymoma is diagnosed when you have ependymal differentiation in a tumor that shows mitosis necrosis. Next slide. I think this is the last one. Okay.
Yeah.
So this was a tanicytic ependymoma, anaplastic, WHO grade 3.
So a few notes on anaplastic ependymoma. Most ependymomas occur in children, and those that occur in adults are quite rare. Mean age is 18 for diagnosis of these. And ependymomas in adults are more often in the spine than anywhere in the brain. In terms of workup post-operatively, it's really important in these patients to do MRI of the spine in addition to the brain, because these tumors commonly do seed throughout the CSF. And another thing about ependymomas in general is that radiation is important. It's been definitively shown to improve survival. And in cases of anaplastic like this, the overall prognosis is much worse. So it's, I think, helpful to think of these really as two separate disease entities. In the literature, interestingly enough, there's actually this tumor in this location have been pretty well described, and they present a lot of the time very similarly to this lady. This picture on the right was taken from one of these studies, and there are a few others. They have described these kind of temporal parietal intraparenchymal tumors that present with impressive amount of mass effect and often after a bleeding. So very rare to have these tumors in adults, but when they do occur, the presentation of this lady is not unusual, perhaps unusual to decline that way in the office, but to present with a hemorrhage is fairly common. So,
and then just Josh, just to note, so we, that patient did get a pan scan, and we did have multiple areas in the spine where there was enhancement in the nerve roots and the lower lumbar spine, and so she'll end up getting cranial spinal radiation because of that. So,
thanks, Dr. Evan. So, on to our last case. This patient's a 55-year-old woman who has a history of breast cancer, diagnosed about 5 years ago. Her disease has been well controlled after surgery and chemotherapy. She's seen on a telehealth visit and presents with 2 weeks of progressive right-sided weakness affecting the arm and the legs similarly. So physical exam, if we were to imagine one, we see that she has some weakness on the right side of the arm and the leg diffusely. The weakness is a little more profound in the leg on the right side than it is in the arm. She doesn't have any sensory changes. She's mildly hyperreflexic on the right side. So, Eva, can you think of some places that the lesion could occur that might cause more profound weakness in the legs and the arms that's affecting both?
It could be either the brain, just the brain, or somewhere on the cervical spine.
Right. Yeah. Can you be more specific with where in the brain?
If it's like on the motor cortex,
Okay.
like at the like the more medial part of the motor cortex, where
Good.
the leg is on the homunculus.
Exactly. Yeah. So those are the two places. So you could see this at the foramen magnum or the cervicomedullary junction, or as you said, if it's in the interhemispheric fissure, could also cause these symptoms. So Eva, what do you see here?
It looks like it's a heterogeneous contrast-enhancing lesion in. It looks like it's above the corpus callosum. It looks like it's extra-axial.
Yeah. So we have a extra-axial enhancing lesion. It looks like it's perhaps attached to the falx, and it's compressing the corpus callosum and the cingulate gyrus. And as you said, it looks like it's extra-axial. what would your differential diagnosis be?
I guess it could be a meningioma versus a hemangioparasitoma, or if they have a history of cancer, it could be a dural-based met.
Yeah, definitely. So it could be a meningioma. Hemangioparasitoma is a good thought. And in terms of dural-based mets, they can definitely also look this way. I listed here kind of the most to least common in terms of dural-based mets. These are all cancers that are known to do that, breast being at the top. How would you access this tumor?
Can you go back to the images real quick?
Sure.
Can you go interhemispheric and like on the like come in through the left side of the falx, like
Yep. Yep. Very good. Very good. And that's just exactly what was done. Interhemispheric approach. What are some important structures that you want to try to identify as you're taking this tumor out?
So I guess the first thing that you would come across would be the superior sagittal sinus. And then you just want to be careful of the bridging veins as well when you're going down. And then as you go down along the falx, you'll see the pericallosal arteries and inferior sagittal sinus.
Yeah, excellent. So, arterially, there's going to be distal branches of the ACAs, and as you said, obviously, you're careful anytime you're working around the sinuses.
Okay, so this is indeed metastatic carcinoma of breast origin. In the center of the field, you have large areas of necrosis and a lot of tumor cells. On next slide, you can see mitosis in the center of the field. And if you look at the tumor cells, there is significant variability in size and shape, which we call pleomorphism. So this is obviously a malignant process. Next slide. Now that we decided it's a malignant process, given the history of breast cancer, we did some stains that will further characterize it as metastatic breast cancer. One of the best stains that we use is GCDFP, or gross cystic disease fluid protein, which, as you can see, is diffusely positive. Next one. Yeah, cytokeratin, which is a pan epithelial marker, is also positive. And next slide. This is GATA3, which we like a lot because it's a nuclear stain and is diffusely positive. So we have three stains that are characterize this tumor as epithelial of mammary origin. So this is metastatic ductal carcinoma of the breast.
And this is our post-operative scan. Gross total resection was achieved. And this is just looking
Ali,
sorry.
Yes.
There's more and more data coming out showing that, the metastatic tumors are different than their primary location. If you found a breast tumor coming from the breast versus a breast tumor in the brain, is there anything on pathology that you see that, you could tell that this is a distant met versus or a dural-based met versus a tumor that was originating in the breast?
On histology, all what we can tell is that it is a carcinoma. It could arise from anywhere. Without immunohistochemistry, it is very, very difficult, if not impossible, to be certain that this is of mammary origin. Did I answer
thanks.
your question?
Yeah, thanks.
Yeah, so in this slide actually is kind of in line with what Dr. Ivan was mentioning. With tumors, with the metastatic breast cancer tumors, there are certain characteristics that are associated with metastasis to the brain versus metastasis to bone or to the lung or to the liver. For instance, this type TNBC basal, you see a much higher percentage associated with that type than you do with some of the other types. And just in general, when you're dealing with breast mets or any other type of mets, you know, a total resection is always best when possible. And with breast cancer specifically, some are somewhat responsive to radiotherapy. Others are less responsive. It's important to, I think, point out with breast cancer specifically that it's becoming more and more a problem for neurosurgeons, because, you know, we kind of think of breast metastasis and any metastasis in general as the systemic disease being what's ultimately going to be the problem for the patient. But treatments have actually gotten a lot better. The chemotherapy has gotten a lot better for these tumors, so they're surviving a lot longer, and neurologic morbidity is more and more a problem in these patients. And unfortunately, a lot of the chemotherapies and the drugs that work well controlling these tumors systemically do not cross the blood-brain barrier well. So this as treatment gets better for breast cancer, it becomes more and more a neurosurgical problem.
Josh, did you guys do an interhemispheric with the patient neutral, or like the ipsilateral side down? What was the positioning? Lumbar drain or no?
No, there wasn't a lumbar drain, and I think this case was done neutral.
Y'all can see my screen and hear me?
Yes, we
Yeah.
can.
Yes.
Hey guys, I'm Elise, was one of the sub-Is. I'll be talking about using smartphone-based accelerometers for outcome assessment after spine surgery. So one of the key questions in modern spine surgery is that of patient selection, and further, the degree to which our patients would benefit from a given procedure. In the past, we've answered this with conventional series and trials, such as the famous SPORT trial. We've been able to have large-scale multi-institutional databases that pool results across multiple centers. And in the past year, we've seen an explosion of novel computational models, such as using artificial intelligence and predictive modeling in the attempt to predict which patients will actually benefit from surgical intervention. And a large driver of this outcomes research is due to the aging population in the United States and other developed nations, and more patients are actually getting the procedures that we're able to offer. But however, as more of these surgeries are actually being performed, we see a bit of a discordance in the recommendations across practices. For example, say a patient comes in with a certain etiology. They may be offered wildly different surgical interventions across 2 different practices. Many of these outcome-based research in the past has been based off of patient-reported outcomes, PROs for short. We're all familiar with the big players, be it the ODI, the SF-36. And while these are obviously necessary and form the bedrock of our clinical practice, there are key limitations with their usage. As we all know, they're tedious to administer and require additional staffing. They only measure patient sentiment at discrete points in time, so you do lose how the patient is doing in the interim. And you have to administer them in a prospective nature, which requires consistent follow-up, which we know is not necessarily feasible with every single patient. Finally, there's a bit of a lack of consistent administration amongst the spine surgical community. For example, there was a recent review of orthopedic spine journals that noted for 1,000 studies, there was nearly 206 different PROs used for outcome assessment. So we argue for reimagining of how outcomes can be measured, and luckily there is a better way. So with the advent of modern technology, we're now able to measure outcomes objectively, and this is something we weren't able to do before the advent of tools such as standalone accelerometers. And you can see there's a study on the right. This is from Stanford, and it was recently published in Nature. And it was the first study to actually tell us when patients had meaningful improvements in their mobility, which is quantified in a tangible way using standalone accelerometers. And this is a really interesting study, and we were really excited about the findings from this, but it again required spending money and investing in an additional device, was a lengthy capture of data. You see there was about a year between the clinical question and research outcomes. And again, we see a problem with loss to follow-up, and you have inherent missing data range because you have to have compliance with these patients actually wearing these standalone accelerometers. So we even argue that there's a better way of doing things objectively. And luckily we have this technology at the tips of our fingers. So with the evolution of smartphones, we now have capacity to have a standalone accelerometer in our pocket every day. So who has smartphones? I know mine is glued to my hip at all times, and I'm sure that's pretty similar for everyone else who's tuning in. And in 2019, Apple alone sold nearly 200 million iPhones, which is about half of the US population. So it's pretty ubiquitous in modern day society. So we thought, why not utilize this tool that we have at the base of our fingers to analyze our patients objectively? So we found an app that's able to query Apple Health data. We were really interested in steps taken, distance traveled, flights climbed. We used Dr. Wang's awake MIS TLIP patients who were already enrolled in the ERAS protocol, so we assumed they'd be getting back to baseline quicker than expected. We contacted and consented them, and we downloaded their data and exported it via their iPhones. You can see the table on the right. This application is able to query the Apple Health data for the lifetime of the phone. So this is a significant amount of data. And what I really want to emphasize is that we were able to build this retrospective database from IRB approval to data collection in 2 weeks. So it's pretty rapid and non-intrusive. So this is just a slide of the demographics of our cohort, but what I really want to point out is that nearly more than half of our population were actually over 60. So contrary to maybe expectations, we had our older population actually have iPhones and have usable data. So this is important because this is the population we want to target as far as does surgical intervention benefit patients that have degenerative disease in this age group. So this is kind of a busy graph. It's our daily average steps plotted by line graph of each individual patient. What I want to point out is that you can see that we have data spanning nearly 4 years, both pre and post-operatively. And then when you pull the data together, you have some meaningful trends. First and foremost, eventually we see a significant increase in mobility from our patients at around 6 to 7 months post-operatively. And this is good because obviously we want to increase the functional capacity with surgical intervention. And then if you look at the other trends, you see the data tells a story that you would assume with clinical intuition. Right after surgery, you see a significant decline in physical activity, which serves as a bit of a sanity check for this methodology. If we didn't see this decline, it'd be a little concerning as far as if this is a feasible way to analyze patients. And then eventually, like I said prior, we see an increase in our physical activity data that surpasses the preoperative baseline, which was good to see. And this was for mean step taken, and we see similar results for flights climbed and distance traveled. This is a single patient example, and this is where this patient got their surgery. Again, you see the acute postoperative decline. Eventually, this patient reaches and surpasses their preoperative baseline. And then towards the right of this figure, you see a decline in activity. You may be wondering, is this a late surgical deterioration, or is it another comorbidity, or what is going on? Unfortunately, this patient was diagnosed with pancreatic cancer, and her activity slowly declined following that. But you can imagine using this tool in conjunction with subjective outcomes and also the EMR to generate a more holistic view of a patient and improve clinical care postoperatively. So conclusions, overall, this study is encouraging for the concept of using these phone-based accelerometers and data garnished to objectively analyze patients to assess physical activity and surgical recovery. Like I said before, is really feasible and rapid data collection and analysis. You can use it as a retrospective tool, which is not, you can't do that with the PROs. And then ultimately you can use it prospectively for real-time patient monitoring. And we're super excited. We just had our main paper accepted at Red Journal. We're excited about the prospect of this technology. Obviously, not without limitations. First and foremost, it's a small population, but again, this was a pilot study. It was more of a proof of concept to see if this methodology was feasible. We don't have any normative population baseline, and this is just because it's a novel technique, so we don't know, we don't have any normative data, unfortunately, to compare it to. There's a question of consistent data capture, i.e. is the patient holding their phone for sufficient portions during the day? And just due to the fact that we were able to garner the lifetime activity data from our patients, we assumed data normalization and these average washouts. And then finally, is the accelerometer on the iPhone accurate? There's been previous studies that validate the accuracy of the iPhone accelerometer, even during slow walking, which is important because obviously our patients aren't speed walking every day. We all know that iPhone is constantly updating their software, releasing new phones every year. So we can only assume that this technology is going to improve in the future. So as far as future directions, we want to include a larger sample population and expand to other neurosurgical procedures. We're currently working with the orthopedist, and we're in process of data collection for joint surgeries. And especially in times like these, when we're moving more towards a virtual platform, we can use it as surveillance during rehab and recovery. You can foster a better clinical relationship with your patients, encourage them if you see they're falling behind in their rehabilitation journey. And then eventually, if you see an acute drop in physical activity, you could suggest an earlier in-person clinical visit before pathology worsens. Ultimately, we want to gather enough data so we can use this as predictive modeling, i.e. when will a patient get better and how much better will they improve for their preoperative baseline. And then finally, an interesting trend, just because of when we recorded or when we were able to acquire this data, it was during the quarantine and Miami-Dade stay-in-place order. And you can see that our cohort overall significantly decreased their steps after the stay-at-home order went into place. And for our study, we compared mobility data to operative date, but you can imagine in the future, you can compare a patient's mobility data to their community or their environment and factor in demography and other epidemiological factors to get a better view of a patient in comparison to the environment in which they're in. All right, thank you. Special thanks to Dr. Wang, who's been a great mentor, Greg, and Dr. Yoon at UPenn. Happy to entertain any questions.
Hey, Annalise, that's really amazing work and fantastic data. I would say it's like a game changer. There's not many things that are game changers in our field. I just think that also the bar that you've set for yourself is very high. Like you're looking at activity, and a lot of people continue to do activity even though they're having bothersome pain. So even if you're seeing those improvements there, it probably means that the success of the surgery is even greater than what you're seeing on your data, because a lot of people will still trudge around and do the things they have to do even though they are in pain. So it's setting yourself a high bar, and despite that, you're seeing changes. So it speaks well for the benefit of the surgery.
Right.
Annalise, Mike Ivan here, a great job. I'm wondering if, I know you said you talked and you looked at distance traveled and some of the other markers and rate of travel. Did you look at some of the other data point collections that you could get from the accelerometer to see if they also correlate, or is there other values you could kind of extract that you haven't looked at yet?
Yeah, so there are other values that we can extrapolate that we haven't looked at yet. We did look at average calories burned, but it was a little bit inconclusive. So the application that we found was able to almost get every parameter from the phone. So in the future, we're gonna more target what we want to do.
Nice job.
Any other questions?
All right, so today I'm going to talk about development of the nervous system. So obviously, life begins after fertilization. The embryo tends to go through rapid expansion and division of the cells up until this point here, where by day 13, the cells have reorganized themselves into two types of cells. You have the hypoblast cells, which are here in yellow, and the epiblast cells, which are up here in blue. The epiblast cells form the amniotic sac, and the hypoblast cells form the yolk sac here. What ends up becoming, the fetus, or is this plane right here, this plate of cells, and around day 13, the hypoblast cells begin to secrete fibroblast growth factor, which induce the epiblast cells above them to begin proliferating. This proliferation causes this primitive streak, which is this line here, and a primitive node. At day 14, the cells at the center of the streak and node involute, creating this gap in between the two sides. This formation of the primitive streak and primitive node is a crucial step, as this drives the formation of the entire nervous system. They've done animal experimental models where they've actually implanted the primitive node from one animal into another, and that animal actually goes on to develop two nervous systems. So this primitive streak begins to secrete growth factors that cause proliferation, and then also causes these cells to become less adherent, allowing these epiblast cells to migrate into the primitive streak and down into the space in between the epiblast and the hypoblast cells. And so by day 16, enough cells have accumulated and migrated through the primitive streak and differentiated into mesodermal cells. The cells that travel rostrally here end up becoming the notochord. And the notochord is a crucial step in the neural system development because it's responsible for formation of the neural plate and many of the other later structures that I'll be discussing in the nervous system. And so you can see here, the cells travel down, they differentiate into mesodermal cells, and then they form the notochord here. So what happens if there's a defect in notochord formation? If there's a failure of the separation between the ectoderm and the endoderm, as you can see up here in A, you prevent formation of one neural tube. So you get two hemineural tubes, and this can lead to a split cord malformation. It's believed that the way this occurs is when the primitive streak is being formed, the cells at the center do not involute, and they don't create that space that allows the mesodermal cells to populate that area, and therefore there's no place for a central notochord to form. So there are two types of split cord malformations. Type 1 split cord malformation is when the two cords are in a separate dural tube with an osteocartilaginous septum here. And then type 2 is when both hemichords are housed in the same thecal sac and are separated by just a membranous septum. It's believed that the separating event between these two types of split cord malformations is whether the endomesenchymal tube has regressed enough to allow primitive meningeal cells to be able to surround each tube individually versus both of them. So these cells, if they can't regress enough, then they form this tube here. So returning back to normal development, by day 17, the notochord has formed, and it starts to secrete growth factors that cause differentiation of the ectodermal cells above it into neuroectoderm cells. Ectoderm default differentiation is actually to become neural tissue, and it requires the presence of BMP4 to block the other growth factors that the notochord secretes in order for the ectoderm to become skin tissue. The notochord induces a thickening of this neural plate here, causes a neural groove to form. These two edges start to fold over. There's the medial hinge, which is at the bottom here, and then there are two lateral hinges at either side. This brings the top of the neural tube together, and they come together and form this neural tube. These green cells here are the neural crest cells. They end up separating, at least initially, the neural tube from the ectoderm. And these neural crest cells are what forms the mass majority of the peripheral nervous system, melanocytes and meninges, autonomic nervous system. This whole process here takes about 3 to 4 days. And so by day 21, the neural tube has started to fuse. And so here's a different look at the fusion of the neural tube. It starts at the midpoint area and continues in a caudal rostral direction. So the formation of the neural tube occurs via primary neurulation. That's the main portion of the forebrain all the way down to the spinal cord. The most caudal end of the neural tube is actually formed via secondary neurulation, and that's via basically first process is the mesenchymal cells condense in the center and they form a thick rod of cells, and then these cells end up reorganizing themselves and creating a new neural tube, and then this neural tube fuses with the main neural tube at the bottom to complete the entire neural tube. So now we're at day 24 of gestation. The tube, like I said, had begun to close, but at day 21, it was initially thought that the neural tube basically closes like a zipper, from the midpoint going rostrally and the midpoint going caudally, but there are actually a couple different points of closure in the neural tube. As you can see in this figure here, the main closure is closure 1, which is and then up into the hindbrain neuropore, and then there's a second closure here, and a third closure from the most anterior part towards the anterior neuropore. So the anterior neuropore is the first, is the most rostral end of the neural tube, and is the first end to close, and that occurs at around day 24. This anterior neuropore ends up becoming the lamina terminalis. And then by day 26, you have the closure of the posterior neuropore. So what causes these neural tube defects? In reality, anything that prevents the previously described process, whether it be teratogens or genetic defects or vascular insults. However, the most well understood and preventative measure of preventing neural tube defects is folate supplementation. Initially in the early 1900s, it was noted that neural tube defects were more predominant in lower classes, and people speculated at the time that it was thought to be due to their poor nutrition. So in the 60s, they looked at whether multivitamin supplementation would actually help decrease the prevalence of neural tube defects. And they did see that result, but they weren't sure which part of the multivitamin was actually preventing these neural tube defects. Researchers later noted that mothers who ended up having children with neural tube defects tended to have lower folate levels in their blood. And so this prompted them to look at folate itself as the main culprit. So a large multi-center trial showed that folate supplementation alone was sufficient to lower neural tube defects. So neural tube defects, these are a spectrum of diseases that are directly related to where the defect is and how large the defect is. In these two examples, these are obviously incompatible with life, but craniorascesis is complete failure of the closure of the first 1 and 2 closures that I had shown in this figure up on the top right corner previously. So you have opening of the spinal cord and a lack of a brain, just since the neural tube never closed. And encephaly is a failure of closure number 2 alone, and the spinal cord can remain normal, but the patient does not have a brain. So many of the neural tubes that we as neurosurgeons tend to deal with are spinal neural tube defects. And again, you can see that there are a spectrum of diseases that range from myelomeningocele to spina bifida occulta. The pathology, again, depends on whether the tube fully closes and if it's able to separate from the surface ectoderm. So starting at the worst end of the spectrum, myelomeningocele is a failure of the caudal neural tube to close. The defect is a failure of the closing of the vertebral body, the meninges, and therefore the neural contents or the neural plaque code actually comes up to the surface through the open defect. You can see here, 85% of these patients with myelomeningoceles have hydrocephalus, and Chiari-2 malformations are almost always associated with myelomeningoceles. Generally, the extent of neurological deficit depends on the level at which the defect is at, but it's not a one-to-one correlation between the level and the motor deficit that the patient has. So management of myelomeningoceles obviously involves prompt treatment of the defect. Patients can initially be temporized by keeping the defect clean and wet before going to the OR. With regards to their hydrocephalus, not all patients need to be shunted or have an endoscopic third ventriculostomy, but if they do have clinical signs of hydrocephalus, they would need those procedures. The treatment of the Chiari malformation is a bit more controversial. Many patients' Chiaris tend to resolve once the myelomeningocele has been repaired. Direct decompression of the Chiari malformation is reserved for the most severe cases in those patients with brainstem issues such as swallowing difficulty and breathing difficulty. And even then, some of those patients don't improve with the decompression. Spinal cord untethering is generally a long-term issue that these patients deal with. After repair of the myelomeningocele, after the surgery, there's a lot of scarring that can take place. And as the patient grows and the cord is tethered, they'll have a low-lying spinal cord and they'll need an untethering procedure later on in life. So obviously, when the patient is born and they have a myelomeningocele, prompt treatment is the right thing to do. But the question was asked, if we can actually treat these in utero, do these patients have better outcomes? So this brings us to the 2-hit hypothesis. There's been increasing discussion of whether in utero repair of myelos can be beneficial to the baby. The 2-hit hypothesis postulates that initially in utero, the spinal cord is developing normally and is not, and if the patient were to be born as such, the patient would not have neurological deficit. However, due to exposure from either the amniotic fluid, direct trauma during the birth leads to the neuronal damage as the spinal cord tissue is exposed to all of these insults. So how did they come up with this idea? So initially, a study at Johns Hopkins took stillborn fetuses that had myelomeningoceles and sectioned the spinal cord. And they saw that the spinal cord just beyond the defect was actually normal in structure. Another study that looked at the fetal leg movements in utero and compared them to after birth. This was a smaller study. It only had 13 babies, but in the study, all 13 of the babies had normal leg movements in utero, which was found via ultrasound. But however, all of them had abnormal leg movements after birth, leading to, researchers to believe that the birthing process was actually what caused the neurological deficit. And finally, another study that looked at the outcomes of patients that were born via C-section before labor started, so therefore before contractions have begun, creating increased pressure in the uterus and could be causing neuronal damage. And 2 years out, the patients that were born prior to labor onset had better neurological outcomes. And so all of this information together prompted a multi-center randomized control study, the Management of Myelomeningocele Study, or MOMS study. The study was actually terminated early because the outcomes for the babies who received surgery in utero were much better than their counterparts. They had improved neurological outcomes, decreased need for shunting, but however, there was increased risk for preterm births for those babies. And ironically, it appeared that the moms bore the brunt of the complications, in that there was increased risk of needing for transfusion. There was increased risk for placenta abruption, and further issues with subsequent pregnancies. So it's still a topic of controversy whether or not repairing these myelomeningoceles is the right thing to do in utero versus just waiting for the patient to be born. So continuing along the spectrum, from myelomeningoceles, we come to meningoceles. This is just an outpouching of the meninges through a defect through a bony defect. These can occur at any point along the neural axis. In the cervical and thoracic cord, it is generally due to failure of the separation between the neural tube and the ectoderm. This prevents the mesodermal cells from populating that space in between and allowing proper differentiation into the muscle and bony structures that would keep the thecal sac in place. Unlike myelomeningoceles, alpha-fetoprotein is normal since there's no opening of the meninges. And in the lumbar spine, it's, instead of it being due to failure of separation between the neural tube and the ectoderm, it's usually due to failure of that secondary neurulation process that I had discussed. And so last along the spectrum is occult spinal dysraphisms. The most benign of these is spina bifida occulta. This just tends to be an opening in one or more of the spinal vertebra. The spinal cord itself is normal. The thecal sac is in place. It's just the vertebra does not fuse in the spinous process. Sometimes the only clinical sign is a tuft of hair above the defect. Next, abnormal phylum terminale. This is when the secondary neural tube fails to regress properly, leading to a tethering and a low-lying cord, which you can see here on this rightmost image. We have the low-lying conus down to here, and this is the abnormal fatty phylum, which is hyperintense on T1. And then lipomyelomeningocele and lipomeningocele and lipomas. These are all obviously of spectrum disorders that are due to retention of mesenchymal cells within the neural tube. This is usually due to premature disjunction of the neural tube from the ectoderm before the neural tube itself is actually closed, which allows these mesodermal mesenchymal cells to enter into the neural tube, and they end up differentiating into these lipomatous masses. These tend to lead to low-lying conus, and these patients require an extensive surgery to remove the lipoma from the nerve fibers and untethering to prevent further neurological deficit. And then finally, last on this list of neural tube defects are encephaloceles and encephalomeningoceles. Here we have normal formation of the neural tube. However, there's improper separation of the neural tube from the ectoderm. And as you can imagine, this prevents the mesodermal cells from populating that space and forming muscular and bony structures that would normally separate the neural elements from the skin. They can also be due to amniotic bands that strangulate parts of the head, causing non-anatomical encephalocele. And what that means is that these encephalocele are irregularly shaped and are not along the midline. They can be anywhere along the side of the temporal lobe or occipital lobe, but sorry, not occipital. Interestingly, there's an occipital encephalocele and an anterior encephalocele. The occipital encephalocele is more prominent in North America. You can see that on the bottom picture here. And then actually in Southeast Asia, you tend to have more anterior encephaloceles, and they're not really sure why that distribution is true. So coming back to normal development again, once the neural tube has completely closed, the tube undergoes a process called vesiculation. And this is how the subdivisions of the brain get formed. The inner lumen of the tube expands and balloons out, and what eventually becomes the ventricles. But you have four main outpouchings. These are the prosencephalon, which is the forebrain. This will end up becoming the cerebrum and the thalamus, hypothalamus, and pineal gland. Mesencephalon, which is the midbrain, and then the rhodencephalon, the hindbrain, which ends up becoming the pons, cerebellum, and medulla. And then not pictured here is the spinal cord. So as these continue to balloon out, you get secondary vesicles, which are the telencephalon and the diencephalon, which were formed from the prosencephalon. The telencephalon becomes the cerebrum, and the diencephalon becomes the eye, thalamus, hypothalamus, and epithalamus. Mesencephalon is just the midbrain that doesn't have any secondary vesicles. And then the mesencephalon becomes the metencephalon and the myelencephalon. The metencephalon forms the pons and the cerebellum, and the myelencephalon becomes the medulla. So I'm going to focus on forebrain development for the rest of my talk. As the ballooning is occurring, there's a large proliferation of cells in order to create these outpouchings. The crucial step here occurs at about 5 to 6 weeks, and there are three major cleavages that occur. There is the horizontal cleavage, which separates the diencephalon from the optic cup. Then there is the sagittal cleavage, which is better appreciated on this top image here. This is what leads to the formation of the two cerebral hemispheres. And then there's the transverse cleavage, which separates the telencephalon from the diencephalon, so separating the cerebrum from the thalamus and the hypothalamus. And then the formation of these midline structures is the final step in the prosencephalon development. And so the main structure I'm going to focus on here is the corpus callosum. As you can see here, this is the lamina terminalis, which I discussed earlier, which is the remnant of the closure of the anterior neural pore. This undergoes changes that allows for expansion of the lamina terminalis and also creates a passageway for axons to travel through it. So once it undergoes this change, it becomes a commissural plate. The axons in the developing cerebral hemispheres began to transverse over from the opposite side. These connections occur, so you can see here the axon traversing down into the commissural plate and then going over to the other side. This process occurs in an anterior to posterior fashion, so the corpus callosum itself grows in that fashion as well. So from anterior to posterior, the splenium being the last thing that forms. And so by week 16, the corpus callosum has completely formed. So what can go wrong with this process? One of the most common disorders of forebrain development is holoprosencephaly. This is also a spectrum of phenotypes that is due to disruptions in the notochord signaling, and most importantly, disruptions in Sonic the Hedgehog signaling. The timing and the penetrance of these disturbances give rise to the main different types of holoprosencephaly. Alobar prosencephaly is a complete lack of cleavage in the midline, resulting in one large monoventricle. Semilobar is when there's some separation of the posterior elements, but patients will have occipital horns and the posterior part of the corpus callosum. The least severe of these is lobar holoprosencephaly. There is separation throughout most of the brain, except for the most rostral and ventral portion. And the corpus callosum is intact in this situation. Because the notochord plays such a large role in this pathology, that there's actually also disturbances in face development as well. So people tend to say that the face predicts the brain. So in the most severe cases, such as alobar holoprosencephaly, patients can actually present with cyclopsia, with only one eye, because there's just a defect in midline division that extends throughout the entire face as well. Next is septo-optic dysplasia. This is another disease of midline pathology. Diagnosis requires at least 2 of the 3 pathologies, which would be dysgenesis of the optic nerve, the pituitary gland, and the septum pellucidum. The etiology is unclear. It's thought to be failure of the prechiasmatic development, prechiasmatic plate. You can see here the lack of the septum pellucidum, lack of the pituitary gland. All of these patients have some degree of visual impairment, and almost all also have endocrinopathies as well. But many of these patients do not have cognitive impairment and can tend to lead relatively normal lives. Last on this list is dysgenesis of the corpus callosum. As discussed before, it is due to proper formation of the commissural plate that we had discussed. These axons, therefore, are no longer able to cross the midline. This can occur in isolation, but is generally a feature of another syndrome. There's an extensive list, which I don't have the time to go through right now. But because these axons can't cross the midline, the axons form what's called Probst bundles, which you can see here. These form these 2 classic appearances on MRI: the racing car sign on the axial plane and the moose head sign. Just so if you see this in the future, you know that you have corpus callosal dysgenesis. And so again, we return back to the normal development. Once the main structures of the brain have been organized, the brain undergoes huge neuronal proliferation. This usually peaks at around 3 to 4 months at a rate of 250,000 neurons a minute. This all takes place in the ventricular and subventricular zone. Initially, the stem cells undergo symmetric division, meaning that they create 2 daughter stem cells. But later on, they go into asymmetric division, where one's daughter cell remains the pluripotent potential, and the other daughter cell is either a glial cell or a neuronal cell. These cells undergo a to and from migration as this occurs. So during G1 synthesis, up until the DNA synthesis, they move out towards the periphery, and then move back towards the inner edge of the ventricle where they undergo their mitosis. And then in the asymmetric example, one of these two cells will move back out to the outer surface, and I'll discuss neuronal migration later on in this talk. So two things can occur with neuronal proliferation. Either too few cells or too many cells are created. So first I'll discuss microcephaly, which is defined as 2 standard deviations of head circumference below average. This entity became a topic of discussion during the Zika outbreak. So clearly prenatal infections are a known cause. Other examples are CMV, toxo, rubella, or chickenpox. Genetic mutations and vascular injury can also cause microcephaly. In microcephaly vera, the cortex has normal organization. It's thought that these patients just exhaust out their stem cell pool and can't create a larger brain, but the organization and everything else is normal. These patients tend to have a normal lifespan with some developmental delay and or intellectual disability. There's another entity, microcephaly, with a simplified gyral pattern, which is where the gyri do not have normal structure. These patients do not do well as they invariably have intractable seizures and severe intellectual disability. And on the opposite end of the spectrum, we have disorders of increased proliferation. Megalencephaly can be divided into 2 subcategories, metabolic or anatomical. In the former, babies are usually born with normal head circumference, but due to genetic diseases such as like gangliosidosis or maple syrup disease, there's an accumulation of toxic metabolic products that builds up, and therefore the patient's head circumference increases. These patients do not usually make it past their first years of life. Anatomical megalencephaly is generally due to neurocutaneous disorders such as neurofibromatosis or tuberculosis. These patients tend to do much better and lead fairly normal lives. Lastly, hemimegalencephaly, as the name implies, is enlargement of one of the cerebral hemispheres. There's thickening of the gray matter. You can see here an expansion of the ventricle. Usually the contralateral hemisphere is smaller, just due to this larger hemisphere being pushing on the opposite side. This is often thought of as a disorder of proliferation and migration. There are no known genetic causes. It's poorly understood as to why this happens, but clinically these patients present with cranial asymmetry, seizures, and hemiplegia. Many of these patients undergo hemispherectomy on the affected side as their seizures are usually intractable to normal medication control. The last topic I'll touch on is neuronal migration. So once the stem cells undergo their asymmetric division, the daughter cell that is destined to be a glial cell or neural cell will attach to these radial glia cells here, which go from the ventricle out into the marginal zone. The neurons will attach to the radial glia and travel up into their final destination. And the way the cortex is organized is basically the firstborn neurons travel up and they populate this bottommost layer. The next generation of cells travels up just beyond that and develops this next plane, and so on and so forth until the last born neurons populate the uppermost area. The main key genes involved with this process are filamin 1, which is required for the actin cross-linking so that neurons can move along the glia. LIS1, which is necessary for microtubule stability, so stability of the radioglial cells. And DCX for the microtubule associated binding protein that migrating neurons use for migration along the microtubule. There are two types of migration. All cells undergo radial migration, meaning they go from the ventricle out to the periphery. But once they're there, they can travel along their layer and travel tangentially, such as like these cells. So here are some disorders of migration: lissencephaly, which means smooth brain, can range from the most severe form of agyra, which is here. You've seen there are no gyri in this brain, to a less severe form in local decreases in sulsation, pachygyra. The classic form of lissencephaly is due to mutations in LIS1 and DCX, which I just described, which is important for microtubule stability and the proteins associated with it in terms of allowing these neurons to migrate to their final destination. These patients tend to suffer from intractable seizures due to the disorganized nature of their cortex. So you can see here, in normal cortex, we have the 6 distinct layers, but in lissencephaly, due to the defect in migration, you'll have combinations of certain levels. The newer cells don't make it all the way up to where they're supposed to be, and this disorganization tends to cause intractable seizures. A lot of these patients start off with hypotonia and progress to hypertonia. And unfortunately, these patients tend to die within 10 years, mostly due to aspiration episodes leading to aspiration pneumonia and death. Next is gray matter heterotropia. This is, again, a spectrum of disorders that depends on where the deposition of abnormal gray matter is in the brain. The periventricular subtype is deposition of neurons along the ventricle. You see here. When it is bilateral, like in this picture, it is due to an X-linked inheritance in filament 1. You actually tend to see a predominance in female, which is not usually what you see in X-linked associated disease, but that's because it is fatal in males. Those patients don't make, those babies don't make it out. 90% of these patients have seizures, but they have normal intelligence. Subcortical gray matter heterotropia comes in 3 different forms: multiple nodule, curvilinear ribbons, or a mixture of both. So this is curvilinear ribbons. You can see that there's deposition of gray matter in the white matter tracts. These patients tend to have weakness, spasticity, and seizure onset within the first decade of life. Lastly, marginal glioneural gray matter heterotropia is the worst of all 3. Here, the neurons actually breach the peel surface and cause abnormal scarring between the different gyri. There's low survival past 1 year of life in these patients. Schizencephaly, this was initially thought to be a disorder of purely migrational defect. However, now it is thought to be due to a combination of both vascular insult and migration defect. These two together result in either open or closed defects. So open defects meaning that this cleft here actually opens up into the ventricle, versus this one here, which doesn't quite make it to the ventricle. So this is a closed defect. The open defects tend to have poor prognosis. They're 63% of the time they're unilateral, and 80% of these patients go on to have seizures. And so when it all goes right, you have something like this. And that's it for my talk.